name is Ronen Shechter, and I'm an assistant professor at Johns Hopkins, Baltimore, Maryland. I'm excited to share with you. Sorry about that. Okay. Sorry, guys. Sorry, everybody. Yeah. All right. So I'm from Johns Hopkins. I'm excited to share our personalized perioperative pain program. I have no disclosures. And again, just to confirm, because I have like two screens on my end. Like, do you see the slide of this disclosure, or what do you see? Olivia or Gabriela, do you see my screen of disclosure?
Yes, we could see your screen.
Okay.
We can see your screen, doctor.
The disclosure, right?
Disclosures, yeah.
Gotcha. All right, thank you. All right, so in the late 1990s, the healthcare providers began to prescribe opioids, pain relievers at greater rates. This led to extensive diversion, misuse, and increase of opioid overdose deaths. In 2015, more than 33,000 Americans died as a result of an opioid overdose, including prescription opioids, heroin, and synthetic opioid fentanyl. In the next years, it kept increasing, and opioid-related overdose death was more than 42,000 and 47,000 in 2016 and 2017, respectively. Now, if we focus on prescriptions opioid overdose deaths between 1999 and 2015, more than 568,000 overdose deaths occurred, and out of that, 183,000 were related to prescription opioids. CDC estimated that in 2015, 12.5 million people misused prescription opioids. And among heroin users, 75 heroin of urban areas. The economic burden from the opioid abuse is tremendous. It was estimated to be $504 billion in 2015. Out of that, $431 billion in estimated costs associated with fatal opioid overdose and $72 billion in costs associated with non-fatal abuse and dependence due to increased healthcare costs, criminal justice spending, and reduction in productive employment. In a study by Dr. Bertram, which was published in Lancet, daily opioids analgesics doses per million inhabitants was calculated worldwide, and comparing 2001, 2003 to 2011 to 2013, at the bottom, a substantial increase occurred in North America, Western and Central Europe, and Oceania. Use of opioid analgesics has increased but remained low in Africa, Asia, Central America, the Caribbean, South America, and Eastern and Southeastern Europe. A growing amount of attention is rightly being paid to the widespread practice of prescribing opioids for post-surgical analgesia. In 2012, almost 10% of all opioid prescriptions were written by surgeons. And in Australia, surgeons are responsible for more than 6% of patients being initiated onto opioid therapy. Now, a systematic review by Dr. Bickett, which was published in JAMA Surgery, found that in some surgeries, more than 90% of patients reported unused opioid analgesics after surgery. Now, besides quantity of prescribed opioids, length of supply also matters. CDC found that transition from acute to long-term therapy can occur very quickly. The graph represents sample of opioid-naive, cancer-free adults who receive a prescription for opioid pain relievers. The chances of chronic use begin to increase after the third day supply and rise rapidly thereafter. This supports the CDC recommendations that treatment of acute pain with opioids should be for the shortest duration possible in order to mitigate the chances of unintentional chronic use. Now, surgery is also associated with an increased risk of long-term opioid use, a phenomenon known as persistent post-operative opioid use, or PPOU, and various definitions can be found in the literature. Per the American Society for Enhanced Recovery, the incidence of PPOU is from 6% for all surgical opioid-naive patients up to 35 to 75% for surgical patients who use opioids preoperatively and for patients with history of depression, substance abuse, and preoperative painful conditions. Now, 2017 is when we all got alarmed by the opioid crisis that has crept up on us. As a result, in 2017, Health and Human Services declared a public health emergency and announced a 5-point strategy to combat the opioid crisis, to empower local communities on the front line, and its priority goal was reducing opioid morbidity and mortality through better addiction prevention, treatment, and recovery services, better data, better pain management, better targeting of overdose reversing drugs, and better research. On September 17, 2018, the US Senate passed the Opioid Crisis Response Act that authorized the budget totaling an estimate of $7.9 billion to support fighting the opioid crisis. Now, from all the things we learned, we assumed that focusing on pain control and opioid prescribing perioperatively should be helpful to combat opioid-related harm, and this can be achieved by identifying high patients and mitigating risk, by reducing perioperative opioid use, and by minimizing excess prescribing opioids, particularly in the light of studies suggesting opioid overprescription among surgical patients. So as an academic institution, we had an opportunity to design an innovative program and change how opioids are managed perioperatively. Our team recognized an opportunity to provide more comprehensive care for opioid-tolerant surgical patients by weaning opioid before surgery, by tailoring the anesthetic plan to utilize non-opioid interventions, and by following up after hospital discharge. Building an interdisciplinary team composed of clinicians who specialize in acute and chronic pain, psychiatry, addiction medicine, allowed for personalized treatment plan and address high-risk comorbidities. And before launching the program strategic planning, including an interdisciplinary team, surgeons, and administrators. In June 2017, the Johns Hopkins Perioperative Pain Program officially launched. Referrals are usually made from the patient surgeon, primary care physicians, psychiatrists, pain providers, and anesthesiologists. The criteria for consultation are chronic opioids, history of opioid use disorder, patients on medications-assisted treatment such as methadone and buprenorphine, and opioid-naive patient at risk of PPOU. Through history, physical exam, and chart review, we learn about patients' opioid use, chronicity of pain, etiology of pain, anticipated surgical pain burden, and coexisting medical and psychiatric conditions. We calculate milligram morphine equivalent and patient fill-up surveys, which help us further learn about their pain, function, sleep, and coping skills. A considerable portion of the initial consultation is spent on setting realistic patients' expectations, educating about multimodal analgesia, and providing reassurance that the multidisciplinary team will follow the patient throughout the perioperative time period. We initiate an opioid weaning protocol and multimodal analgesia, and we communicate the plan with the primary surgical team, the anesthesiologist, and the acute pain service. Looking at the first 9 months outcome, we found a significant decrease in morphine equivalent at 3-4 months after surgery relative to time of surgery. Patients who had their first visit before surgery also showed a substantial perioperative reduction in opioid use of approximately 50%. The decrease in MME, or morphine equivalent, coincided with a significant decrease in visual analog scale pain rating starting at 1 to 2 months postoperatively, with a significant improvement in physical functioning as measured by SF12 at 2-3 months, and with a significant decrease in BPI pain interference score at 2-3 months postoperative. These data showed that the multidisciplinary perioperative pain program weans patients from opioids before surgery in patients on chronic opioids and along the postoperative phase while improving function and pain control. Looking at length of hospital stay, for all JHH surgical patients in 2018, it was 6.5 days, and specifically for spine surgery, it was 7.6 days. For patients who participate in the program, it was only 5.8 and 5.2 days respectively. The tools that we use are multimodal analgesic regimen, which has been discussed earlier, multidisciplinary team, and last but absolutely not the least, patient motivation. Now, if we talk about the multimodal, systemic pharmacologic modalities involve non-opioids such as acetaminophen, NSAIDs, NMDA, receptor antagonists, anticonvulsants, alpha-2 agonists, and local anesthetic, topical and systemic. When appropriate, patients receive regional anesthesia based on the surgical indication. Using chronic pain intervention can also be helpful, and we're using them frequently. And as we are managing pain in acute and subacute phase, in cases when patient cannot wean off opioids, we transfer their care to a chronic pain clinic or back to the provider who managed it prior to surgery. We are also very fortunate to have a psychiatrist on our team. And besides pharmacologic treatments use of cognitive behavioral therapy, mindfulness, relaxation, group and family therapy can be also helpful. Increasing number of patients that we see, unfortunately, in the acute phase suffer from polysubstance use disorder. Most of them are admitted through ED after a trauma or due to an infection. Our team collaborates with addiction medicine to manage this changing patients' population perioperatively. Now, about motivation. If patients are motivated, their success in weaning down opioids increases. There are many studies to show. What we try at the clinic is to move the chronic pain patient from expecting to be fixed and cured and have their pain eliminated for good, to being interested in living with less pain and willing to learn and explore new ways to cope with pain based on what they can do for themselves. In 2018, the Health and Human Services reported that from 2017 till 2018, there was a decline in drug overdose death in the United States, and that the number of substance abuse facilities and patients receiving medication-assisted treatment, such as methadone, buprenorphine, has increased. In contrary to 2016, where there was an increase in prescription opioid overdose death in all sizes of urban areas, in 2018, compared to the year before, there was a decrease. So we have a happy ending. Well, unfortunately, not yet. If we look broader and beyond 2017, we can see a decrease in overdose deaths from prescription opioids. However, total opioid overdose death is increasing in an alarming pace, mostly from non-prescribed opioids like the fentanyl. In 2020, close to 69,000 Americans died as a result of opioid overdose, and this is 21,000 more deaths compared to 2017, when it was 47,000 opioid-related overdose deaths. So, to conclude, what we have learned since the clinic has launched is that interventions have been successful in preventing escalation of prescription opioids overdose deaths, though it is still there and we have much work to do. Now, focusing on substance use disorder patient population is the key to slow down and possibly reverse the trend in opioids-related overdose death. And the most important thing, which our clinic addresses, is that the perioperative period is a window of opportunity to catch these patients, as it is more likely for them to be motivated to make changes and recover from their addiction. Right. So thank you. And if you're interested to learn more and build a perioperative pain program, please, you're welcome to contact me. Thank you.